meeting where we are going to discuss and agree on a number of things. I want to bring you greetings from the Ministry of Health, the National TB and Leprosy Program. At times we still call it a program, but it's now a division, now that is headed by the Assistant Commissioner. So I'd also bring you greetings from the Assistant Commissioner of the Ministry of Health, National TB and Leprosy Division. Once again, I'm Dr. Raymond Biaruhanga. I work with the division. I'm a senior technical advisor for the Global Fund as well as US government funding support. This morning, I bring you apologies from our Assistant Commissioner, Dr. Stavia, who is equally in a very important meeting that I also had to leave. Has to do with also the Global Fund. We have great opportunities now that funding is increasing in the TB program. And this is partly appreciated and brought about by such activities like the one we are doing, or we are going to do. The purpose of this meeting today is we want to look at clinic versus the hotspot, active case finding. As a National TB and Leprosy Division, we've taken on a very important strategy, and that is the research agenda. It's part and parcel of our objectives in terms of doing more and more research. And we want to appreciate the Makerere University College of Health Sciences, together with the Uganda TB Implementation Research collaboration consortium, in terms of the researches that they are bringing out, they are doing and bringing out. You know, a number of researchers, especially many of you have been engaged in these research areas. So, as a TB program, one of the areas we are embracing very seriously is research. We are now past the history of, implementing, because, this is a policy from WHO, this is a policy from one person or so. We want now to test our strategies and see how they work within our context. So this is one of them. We've been grappling a lot with active case finding. For most of the districts probably here, a number of you have been in active case finding. We have a toolkit which we launched some time back by the minister, the active case finding toolkit. And as a result of that toolkit, we have a 10-point package, or 10 strategy package that we want to implement. And one of the activities we really want to implement, for one of those strategies, one is the clinic, the health facility, active case finding. But now, of recent, you must have seen, especially through the catch-up campaign, the CAST TB campaign, we've gone to the community. So we are really trying to see, where do we find the people missing with TB? Now we've moved to the community because there is a lot that we believe from the prevalence survey that has resulted in finding those people with TB at the community. And most of you who have been implementing the CAST TB, you must have seen this, that we're actually finding people who have been missing, who would not even have thought would ever come to the facilities for screening and testing and diagnosis for TB. And we are finding them. So, as a result of our prevalence survey, we have been able to find people missing with the TB at the facility level. We are now in the community doing CAST TB. We've been doing catch-up campaigns. I know many of you have been now in outreaches working with the implementing partners that are here to be able to find those people missing with TB. The question is, how cost effective is it? How implementable is the CAS TB campaign? How implementable is the community TB contact tracing, contact investigation, of finding those people missing with TB? Yes, we have the numbers. We can pick up the numbers. Is there any way we can find it much easier? Can we have less of the funding and more of finding the people missing with TB? And that's what we are grappling with today. We have introduced the digital X-ray. We're in the process of introducing even more technologies in terms of TrueNAT. We had the Gene Expert, we want to add the TrueNAT. So we want to add a lot of other technologies to make sure that we find those people missing with TB. But even when we find them, make sure that they are put on treatment. So the CHESS activity that Dr. Katamba and the team are putting together for us to do is we want as a program to know how cost effective is it, clinic versus the hotspot. How implementable is it within the bigger context? So we want to appreciate Dr. Katamba, but we also want to appreciate the facilities that are going to be engaged. We also want to appreciate our implementing partners for giving us the opportunity that in the facilities that we want to implement this activity, they are going to support other activities, but we are going to be able to make sure that this takes root, to avoid bias of results, because we might work with the implementing partners and then tomorrow the implementing partners are not there, and as facilities we are left stuck. So we want to see how can we do it irrespective of the implementing partners being there. So we want to appreciate the implementing partners as well. Let's take this as one of those activities where you people at the facilities are going to be our pioneers in finding out some of these strategies that we have. I want to, and I'm sure we shall continue interacting together at the facility level. We shall meet again here and discuss how far we've gone or how we are faring. There are going to be challenges, but how do we make sure we document those challenges such that when the program embraces this strategy, whether it is the clinic versus, or it's the hotspot strategy, whichever is cost effective, whichever is implementable, we also are aware of those challenges and we are able to address them together. There is nobody else who is going to do, for example, if we take it on, we are going to have to bring you on board to be our trainers in other regions. So we want you to be very active. We want you to take it serious. We want you to give us the results that we need, or we expect. We want you to be more interactive with it. And I know many of you, the facilities that have been here, have been engaged in other researches, and you've done a very good job. And we've taken on some of the recommendations from those researches that have been done by Makerere University College of Health Sciences. So let's use this opportunity to make sure that we have our names written in the archives of the National TB Program, to have found those people missing with the TB and put them on treatment. I want to thank you once again, and I'll stop here and we continue the meeting. I officially open this meeting. I'm not used to anything. Thank you.
Yeah, I think Dr. Raymond seems to be ready for 2026. Looks like he has already. Okay, thank you very much, Dr. Raymond, and on behalf of the Assistant Commissioner. I also learned today, learning does not end. I also learned that it's now a division. I have been calling it already. So you see, every day you learn something. So I've learned. So now from that, I want to take you through what is it. Before we go to the actual activity of randomization, we need to understand what is it that we are going. And so now I'm going to make a small presentation. Feel free to interrupt me and ask any question that is not clear. But I want to say this word CHESS is about what? CHESS TB. Even Some people are not putting on their t-shirts, so all these people did not give them, or they are very small, I don't know. But at least everyone is, we are chasing what? TB. So we want TB to be chased out of Uganda. And I think the program is doing a very good, the division is doing a very good job. I need to online, both School of Medicine and School of Public Health. Our colleague who I told you went back is in the School of Medicine. And David Daudi, who has just talked to us, is in the School of Public Health. And we have the Center for Research at Johns Hopkins, we have Ministry of Health, Makerere University, Uganda TB Implementation Research Consortium. And we have what we call WALIMU. WALIMU is also another partner organization. So these are the partners who are, and now we've added you who are going to be even the more key partners in this. Just a small outline of this presentation. I'm going to go through a few things and give you a small background on what it is. So, we are all aware that TB is still a problem. And as you know, even COVID wasn't it. It is still estimated that about 10 million people who develop TB disease each year, nearly 3 million are never diagnosed and reported. And I think we ask our secretariat to make sure you provide these slides to these people, whether electronic or what, so that people can have this. So, as you can see, still there are people who are not diagnosed and left there in our community. And as Dr. Raymond said, our prevalence survey even showed us that there were people even who were waiting for people coughing, but half of the people who were identified during the prevalence survey did not have any cough. And they had TB and they had been diagnosed based on X-ray. So, for each annual TB diagnosis, there are up to 3 people with undiagnosed TB. And those people are smear positive, meaning they continue to transmit the disease in the community. So, in order to reduce transmission, we need to find TB earlier in its disease course. That is through systematic screening and active case finding. And the work we are going to be doing together is going to be focusing on screening people in the community, screening whoever comes to the health facility. And then, at the end of the day, identifying those people early. Because I may come for a different service, malaria treatment or any other antenatal, or I may come for family planning at the clinic. That's what has brought me. But we want to take advantage that whoever comes at that clinic, and there is no contradiction to screening, we screen him for TB. If we capture him there, we treat him. And those who require preventive therapy, then we also put them on preventive therapy. So, there are many technologies that have come out, and we use some of this right now. Many of you are using these technologies. There is the mobile digital X-ray, and these days can be interpreted very quickly and accurately in the field using artificial intelligence software. Before we used to say we need so many radiographers to read the X-rays. Now, people have developed the CAD and many other softwares. They will read and interpret to you the X-ray. So meaning, and the national program has bought many of those through Global Fund. They even bought very big vehicles now, which are available, and I'm told there is going to be also gene expert. They go in the community and screen and also do it. So there is already this technology. The gene expert is available in most of our clinics where we are coming from. Treatment, there is effective treatment. And of recent, there are studies which have shown that TB treatment should be shortened to 4 months. You see, even preventive therapy treatment, isoniazid, we used to have 9 months. You have to take 270 doses if you look at the 9 months. And compliance, things were not easy. People could not adhere to their treatment. But now, there is what we call 3 HP, 3 months and taking weekly dose. There's even brought 1 HP. So there are many now new interventions. But despite being there, if we don't use them wisely, we can continue to suffer with TB. While each component of this intervention has been rigorously tested, it remains unclear how best to implement all components in combination. So, all of these are there, and each has been implemented. This study is going to show, if we put all of these things together, what is the impact on TB? What does it cost? Like the program manager said, what does it cost? Because the program may say now, this is a good intervention. We want to implement it through the Global Fund. How can we implement it? How much does it cost if we are to budget for it? So, the issue of TB preventive therapy with active case finding. We want to add, in addition to active case finding, we want to add on TB preventive therapy. Treating latent TB infection with TB preventive therapy is an essential part of ending the TB epidemic. So ruling out active TB during active case finding, even with negative X-ray or expert results, it provides us a good opportunity to deliver TBT to those who will benefit. So, using X-ray, we shall use TST, and those people who qualify and appear to be positive for TB infection, then we shall give them preventive therapy. The TB preventive therapy that is going to be given, we want to implement this in a pragmatic way in the program. We are not going to be establishing any treatment centers anywhere. No, the patients will be using the services that are available within the existing health infrastructure. The staff we are working with, we are not bringing any new staff to those health facilities. At the end of the day, when the study ends, when you have put staff, then everything collapses. Why not work within the existing system and know what it costs, even if you have added ABC? And so, we are going to be having also TB preventive therapy in addition to looking for people, and those people will be accessing care at your health facilities. How did we come up with this study? So, this scaling up of active case finding and TPT in Uganda. Earlier on, we did a study which ended, and this was based in Kisugu and Wabigaro in Kampala, here in Makindye Division. Those were the two parishes, Namongo and others. And that study was led by David Daudi, who was on. We went to all those communities and we were screening house to house. We were screening for TB in every household to make sure that whoever we capture early. But we were also at the same time organizing venue-based screening. You bring some bit of music here at the church on a Saturday and you tell people we shall be work with the LC people, and you tell them we shall be screening for TB. And the people come. And the people came. They could screen 150, 180 people on a day. You screen, take off sputum, carry it to Mulago, and test it with the expert, and even those who are positive, we do culture and other things. So, we did that study. That study is what informed us to move to this bigger study of X-ray. One of the things we found in that study, venue-based screening recruited a different and higher risk population than door-to-door screening. So as you know, even during CAST interventions, those people that sometimes when you hold those screening, when you screen people in the community during cast, the people you get during that time are not the people who come to the health facility. So we realized that the people we screened when we went door to door, then also we put that we talk to the LC, talk to the people in the leadership, where should we put and on which day they put here around the marketplace. The people who came to the marketplace were different from those we found in the homes. Meaning that if you focus only on household, there are people you miss. There are people like Boda Boda and other people whom when you put music there and say you come and I take off a sum, they will come. But if you go home, you will never find them there. They either come back late or what. So in a way, screening people at the very best is important and identified. In Kisugu and Wabigaro, 5 zones with the highest baseline notification rates. By looking at our register at Kisugu Health Center, and we saw which zones most people were being notified from, accounted for 22% of the community population. If you look at the population, those 5 zones could only account for 20% of the population. But 46% of all undiagnosed prevalent TB cases. It means if I look at my TB register and I see where most people come from, it can tell me which areas might be hotspot, where I need to focus my attention if I'm to hold very best screening. And that's a key message which we learned from them. And informing us that to say we can work with health facilities, find out which are the hotspots based on the data in the registers, but also based on their knowledge as BTLS, zonal and clinic people who may know which might be the hotspots. And then we shall identify those hotspots based on working with the people within those clinics. So participants also, when we ask participants, where would you want you to be screened for TB if there was an opportunity? Participants also named health facility waiting areas as their most preferred TB screening. This study informed us that about facility-based study, venue-based. So this study informed us that, yeah, as we did this study in Wabigaro, we may need to do hotspot screening, which is like venue-based screening. We may need also to put in consideration health facility cleaning. That's why in this study we are proposing, there are 2 interventions. We shall be screening in what we call hotspots, we shall identify together, but we shall also be screening at the health facility. We've been to most of the health facilities, if not all. And we are going to work with you to identify, or we've already talked about it, to identify which place can we put a tent at the health facility OPD, and also put a screening for X-ray, so that whoever comes through the door and is eligible should be screened for TB. And whoever we find that has got an abnormal X-ray based on the software reading it quickly, we should send him to provide a sputum, and it will take off a sputum and sit down in expert, so that that person, once found to have TB, he came for family planning, but he was found to have TB. Why do we leave him to go back in the community to spread the disease? And so we shall have that, but also we shall have the hotspot. Any questions? Okay. So next, we shall look at, yes?
In some instances,
Yeah.
you may find that you send the patient there, and then the result comes out to be negative. But then, you're saying the X-ray is abnormal. What do we do in such circumstances? Because ideally, if the X-ray is abnormal, I think I would just treat this client.
No, we don't want just treat. The X-ray abnormal may mean other things. There may be other chronic obstructive pulmonary disease issues. And probably if you really see this person may not have TB, But as a clinician, if he evaluates that clinically, based on the negative expert and the other clinical findings beyond that, history of contacts and anything, you should still treat. But the issue that he just not only the X-ray as a way, but the other tests you can do, like symptoms, signs, and others. Yeah. So, thank you very much for that. Yeah, so this is the chest TB study. We want chest TB out of Uganda. Our overall goal, we want to evaluate the comparative effectiveness and the implementation, as you heard Dr. Raymond tell us, of this combination intervention. It's combination between active case finding and TB preventive therapy. It is, we are going to find those screen people for TB, but those also who qualify for TB preventive therapy, they will be referred for TB preventive therapy as per our guidelines. You know, the national guidelines, whoever is HIV positive and has not had TB preventive should get it. But even there are people who are close contacts with him and others. So the combination intervention is active case finding and TB preventive therapy. Under two different approaches. The two different approaches are going to be, we shall screen people at the clinic. We shall also screen people in the hotspot areas. And we want to compare what is the yield if we wait for people to come. But as we said, even the people who may come to the clinic may be different from those who remain in the community. And so, but what does it cost and others? So, we shall compare the effectiveness of the hotspot focused versus facility-based active cell and the linkage to TB preventive therapy in terms of the number of individuals who are started on treatment for microbiologically confirmed TB. And the numbers of people, where are we going to collect it? From the TB registers. We shall be capturing information, all the data of all those people we shall screen in the community or screen at the facility should end up into the national TB registers. We are not introducing any tools to collect that data. That data should go into the national. What we shall do to evaluate our intervention, we shall go and take photos of those registers and be able to know the data, but the data will be captured in the registers. The data for those who will be put on preventive therapy will still be in the registers of the clinics. We are not introducing any tool to that, but we shall be sending people to get those services. Where need, we shall be paying transport to these people, because if you find someone in the community hotspot and he has to go to, then we've agreed, and the funds that has been accepted by IRB, to pay some people, is it 10,000, 15 or 20, to be able to access the services. If found to be positive, X-ray during hotspot, then we shall be able to facilitate those people to reach there and be able to be evaluated at the clinic and do that.
Excuse me.
Yes.
I wanted to know which register shall we use for collecting data for those screened in the community?
The register?
Yeah. Because at least at the facility, we can use the OPD.
No, we are not going to use particular register in the community. Whoever shall screen, if we screen you negative, complete and continue. If we screen you positive, we refer you to the facility. But then we need to see how many of those we refer to reach there. So we shall have at least a result. But we are also trying to see if he's going to go, we should provide him transport to go there. So that we don't have like having to keep register every day. Thank you. So we shall measure the implementation of the hotspot and facility-based active finding plus TB preventive therapy, including the reach. There is in every area, you may say, this place has got 10,000 people. How many of the 10,000 you thought that are there you've reached? How is the implementation? How can it be maintained? And what are the costs? Our colleague online is a guru in modeling. He models the cost effectiveness, is an expert. And so we shall look at the cost and cost effectiveness of that. And also estimate the impact of intervention in diagnostic delay and TB prevalence. You know, there is this issue of if everyone used the condoms, if mother-to-child transmission is like this, what will be HIV in 10, 15 years? You've seen those reports. So people, based on the interventions that are there currently and what they project things may be, to project what the future will be. Things may change. So if at all we've got data from our communities, how the hotspot screening and TPT preventive therapy works, then people can estimate very well what would be the impact if at all the national program implemented these interventions in the communities, even what would it cost and other times. It's like screening for cervical cancer. You know, when you screen, you lose the money because you screen early, isn't it? Because you are screening early, this money, if you did not screen, you would be using it. But then, if you don't screen, many people in the population get cancer because you did not screen early. The downstream cost is far, far higher than what you would have spent. So you would spend in screening, prevention. Same things you would say that, yeah, if I don't use this money early, it's like GeneXpert and sputum smear microscope. GeneXpert is more expensive than sputum smear microscope. But it misses many cases. Those many cases continue to transmit disease in the community. Finally, you may capture it, but the burden continues to take longer time to clear than when you use better tests. And this is where you can estimate the future of doing this, what would it mean and inform the people. So this is our clinic where we shall put. This is in the communities we shall agree with you which settings to work. Then what are the methods? The methods are sort of put in this one figure. If you look at this one figure, recruitment, people are going to consent orally. I don't think there was written consent in the cast, was there? Could the people, And then we are doing it as a pragmatic, and even presented this to the IRB to really understand that this is not different from the way things are done in the program in routine care. So people will come. Now let's look at a community. We organize, agree with you which area are we going to work. Then we agree we are going to be in this community. We shall put our tent here and some chairs. Our X-ray will be there screening. We shall be taking off sputum from that place. And then usually music attracts people. Put some little music. People start, it may be a market area and you put the tent there. The people come to the market, go for screening. What are these people? And as they screen, you ask them whether they are winning and give them some information about what you are aiming at and what you are screening. And once they screen orally, then if someone is pregnant, we will be able to do a test. If unsure, someone if is unsure, pregnant or not, we can do pregnancy test to know that we don't. Usually pregnant mothers are exonerated from that and they can go directly to give a sputum if they have symptoms instead of having to subject them to this X-ray. And then, if no, then the person will go for screening, X-ray, it's not pregnant and everything. We go to screen, abnormal X-ray, then the person will continue. If he has abnormal X-ray can produce sputum, we shall get a sample which is sent for gene expert. And that person, we shall get his or her contact. And once the result is positive, then that person is given transport to go and be enrolled on treatment, be put on treatment at the clinic. So, positive expert, TB treatment. Negative, if someone is negative, we need to evaluate him for TB preventive therapy. May be negative. Some people may know their HIV status, but we shall do, if HIV positive, then that person automatically, if he's not on TB preventive therapy, he qualifies to be. But if someone is HIV negative and we don't know, then we shall give tuberculin skin test, TST. And then that will be read, and if positive, that person will be referred for TB preventive therapy. Negative TST and not known HIV status. So this process will be the same for both people who will come at the clinic tent or at the hotspot. Non-TB abnormality for all the above. And as you asked, these are people who will be referred. He was saying that should we treat them or it may be an abnormality, but it's not TB, then needs to be further evaluated and may have any other condition that may require that. So what, as I said, we shall be abstracting data from the health facility TB register, TB and TB initiations and others from the registers. We are going to be working in the community and the clinic, but these people will be referred to those places. One of the things, the challenges that sometimes comes up, you find that maybe the cartridges are not at the facility at that point in time, and then you are referring these people to get that. And the study is putting up a backup system that if there are no cartridges, then we can support during that time and provide cartridges so that the study can continue also. People can continue to use that. We want to see that these go to the normal system instead of saying we are doing it separately, and so that it's still working within the same government structure. Yeah. We will get more to these details also, but now this is going to be a trial. It's that's why we are here. We want to randomize people by chance. As I told you when we were sitting here, there was already bias. There's already bias. If you ask views of people and you ask in this small area, you may find they are giving you views of this. They are similar because they are all coming from. So if you don't select well, you may get what biased. So in a way, this is why we have to randomize. And this randomization, we have multiple period crossovers. What do we mean by that? You can see in these colors, we have community 1, 2, 3, 4, up to 12. And there are 12 facilities represented here. If we knew, we could put that this is Kasambia, this is Gombe, this is what, but we don't know. So you are the ones who are going to put names there at the end of today. So now you can see that there are these few, 1 or 2, 3 months, where we are working with you. We have been already to your facilities. We have been abstracting data from those registers. And that data that has been abstracted is to inform us of what is on ground, what are the TB notifications, what are the differences in these facilities. Because at the end of the day, we want to make sure that the people who end up in these different groups are as similar as possible if we want to make comparisons. That's why some of you have written letters to you allowing us, DHOs, to give us permission to abstract data from other similar health facilities in the district. Because we know that if you refer people in the community to go to health facility for further evaluation or TB initiation, it might not be that we are going to refer them to maybe Bujiri, the main hospital. They may go to where it is convenient. Meaning that when we are abstracting data to inform how we have performed, we will need to abstract data not only at Bujiri Hospital, Iganga, or Zimbabwe. We shall also look at the neighboring, because remember we shall be doing hotspot within the community. And so that's the reason that's it. So you see, there will be individual level intervention occurs at identified community hotspots. So the green color here, after these 3 months of abstracted data, and for others to continue to look at the data coming in because they will not have started. This green shows you that 4 months we shall be in a hotspot. If we come to Sembabule and we sit down, look at the data there, and we work with you, and you say, but I think this area is a hotspot, you should go there. Then we are going to be in that hotspot. We may move from that hotspot to another hotspot within the district or the area you've identified, Dr. Moses there. And then at the end of the day, we shall spend 4 months in the hotspot, having our X-ray there, our people screening people in the community for 4 months. And then after those 4 months, we shall live a period of washout. 4 months we shall not be doing anything in that community, or in Zimbabwe in particular. Then after those 4 months, we shall come back to Zimbabwe in this case. And now we are going to be based at the clinic. We are going to put the tent at Zimbabwe Health Center and spend that tent for 4 months. Whoever comes into the clinic, the staff, we shall screen him for TB, who is eligible. And then we shall leave out a washout period also for 4 months. And then we shall get back to the hotspot in those communities and screen for TB in those communities. This will go on for these years. We are screening for TB, alternating between hotspots. Assuming Zimbabwe is one of those who decides to select to be among the ones which are going to get active case finding and TB. But if Zimbabwe decides to select to be in the control, he will remain in the control and will have data to understand what's going on between this intervention and that. So for those some, now there will be this one which will start at the healthcare facility community for 4 months, washout like this and so on. So even the starting, there are 2 clinics which will start at this period. You will be participating in the selection. Who are the 2 clinics? We are 12 facilities. Among the 12, at the end of the day, we shall know which are 4 in control, which are 8 in the intervention. But even in these 8, finally we need to decide which are these 2 which will start immediately. Which are these 2 which will start at this point? Because it's very hard also to roll out once. You need to do this. Which are these 2 will start this, and which are these 2 will start this? And all of them, as you start that, you continue, and you see, you will have the same period. But who do we start? And this is trying to balance, to make sure that we are not biased in this study, and at the end of the day. So this is how things will be each cluster catchment area of one health facility. So we are looking at a catchment area for Zimbabwe Health Center for or Kasange, but that catchment area may be very large. And now that's why you see there is a time when some DHO said, but who allowed you to go to those health facilities? And then we wrote letters asking them to give us permission to also look at the data, because finally, these patients we shall be screening in the communities will be referred to what is convenient for them and nearby where the service can be provided. So in order to assess the impact of our intervention, it will be important that we abstract the data from all those facilities. And that is a process that we are continuing to do. So which are these? We have been doing a lot of mapping, looking at the areas. Chazang, we were there, Chazang, and this is the place. Sembabuli, we were looking at catchment area. And we're looking at catchment area, we are looking at also the patients in those registers, how far they come from and other places. So it's sort of, we look at Butenga, we looked at Kasambia, Kasanda, Gombe, Nakaseke, Ruwero, Kayunga, Kaworo, Iganga, and Ujiri. And there were others, and we wanted the things to be a little bit. So we looked at many, and this is finally when we looked at clear. So this is how the physical places where we are. And we are going to be, we have already procured 4 X-ray machines which we shall be using in those facilities. And these X-ray machines will be used for the studies, so that in these communities which we are going to be working in, we want to be screening and trying to inform this study, so that the other screening, and we will talk to NTLPA. I don't know whether someone did us here who was, did us here. I think maybe he's caught up somewhere. And we were trying to discuss also with NTLPA to see that as the activities are done, they can focus the resources in more areas. We are going to really focus screening in these areas very intensively where we shall screen, so that we can be able to get data. And so we're mapping out which area, how far the hotspots will be, to be able to inform these studies. So, administration and recruitment across both arms. We shall be a composition. We are having not many teams, we have a 3-person team. A nurse will carry out the intervention in each region during the intervention periods. So at that site, we think 3 people will be manning that, the X-ray and other things. And this is a learning also to some extent from Dr. Aldo, and other people are using this mobile in car. I know in Hamoni, there's also one in Sigilo, so we have been trying to learn also what the Minister of Health is using on this. Team scoop, each team will move between adjacent regions, such that each team conducts screening continuously and spends an equal amount of time doing each of the 2 interventions at the facility and the hotspot. And I have shown you, we shall be spending 4 months in each of those. So we shall really, when we come to your communities, we shall be looking for, this is a hotspot, we shall identify together, and then now spend 4 months. We may say we have spent 2 weeks in this place or 3 weeks, screening every day, inviting people, they are less. Now we are going to this other hotspot within the community until 4 months end. Timing, screening will occur approximately 5 days per week, including at least 1 weekend day per week throughout the 4 months intervention. We want to see that sometimes some people are not there during the rest of the weekend. So you can put a day for screening over the 1 day the weekend, and you invite people next Saturday. There's the marketplace. As you know, these markets we get in the village, some of them come once every month. So location, participant enrollment and TB screening will take place in screening station erected inside the tent. If no easily accessible covered structure already exists. So we are procuring tents, which will be used, some chairs, and some other equipment. As far as equipment is concerned, we have been working closely with the atomic energy as far as X-rays and other things are concerned, and clearance and other things with taxation clearance. Ministry of Health has given us clearance PS not to tax the X-rays. These 4 X-rays will be handed over to NTLP. Or NTLP will hand them over to the communities and others, but these 4 X-rays, at the end of the study, is donation from Johns Hopkins. They are going to be handed over to be added on the X-rays for the program. So issues of safety and anything, we are going through all that with the atomic energy and other things to make sure everything is in line with what is required for the safety of our people. So, close coordination, you are here to seek also your coordination, your support, so that we can coordinate together in implementing this study at those facilities. And so we wanted to make sure that whoever is in that clinic, whoever is in that community, is aware of what is going on. And our staff, whom you've seen, including me, will be seeing us even much more now that for the next coming 4 months. And so you will provide a designated high visibility spot for screening intervention at the facility grounds. We listed even the X-ray places and other places. Where can we keep the mobile X-ray? Where can we charge it or something? And we've been to different places. We have looked at actually the clinics they have space where we can put it overnight for working tomorrow and other things. So we want just closely work with you. Encourage all patients and visitors to participate in screening, irrespective of TB symptoms, as they come and go through their sitting areas. Now, as medical directors, medical superintendents, in charges, administrators, this is something that we are saying, if we are going to do hospital screening, passing that word to the people in the clinic to say that all the people, as they are waiting, they should go and screen for TB for free. And so all those people who come to the clinic, they can go through that screening tent. And they are screened for TB once they are eligible. And then if found TB, they will be treated. Those eligible for TB, so we are taking advantage to screen and initiate either treatment or TB preventive therapy and reduce transmission within our communities. So, recruitment during hotspot focused intervention, health facility involvement in hotspot selection. As I told you, we are going to involve you to identify what are the hotspots in this area. As I told you, hotspots can also be, when you look at your TB notification data, you can do in that community, there are many TB patients who come there. Maybe we need to go there and do thorough work. So prior to each hotspot intervention, a designated member of the health staff will help select hotspot parishes likely to have high burden of undiagnosed TB. Yes.
Excuse me, one thing remains unclear to me.
Yeah. The cases did not fly out of the ground as it was reported. Please.
Okay, thank you. Something is not very clear to me about the hotspot. When we receive patients who are positive, how many should we consider to be a hotspot? And in a district like Luwero, if like we have 100 cases at the hospital and maybe 100 cases somewhere else, should we assume that all areas shall be covered as hotspots?
Yeah, and this is a challenge in administration that Luwero gets these patients who come in the register. By looking at their register, could you say which parishes most people come from? And also from your own other insights within the area. Because as we know, TB is a disease of congestion and other things. You may still say, yeah, we think this is an area which is hotspot based on the data we have, but that is something we shall be working together with you to identify, because this time, hotspot these first 4 months. Next time when we come back, you may realize that there is another hotspot. It's not necessarily the way we went last time. That's why we still come back at that time and say, based on the data of notification and others, is it better if there is another hotspot to focus on, or we go back to those hotspots? So that's how we tend to do it, and trying to focus on which areas. Sometimes they may be 2, 3, and we focus 4 months there. But you may say, no, this one, first priority. Maybe let's spend 3 weeks there. Let's spend 3 weeks here. Let's spend 3 weeks here. And even within that place, you may say, there is a market here. But then down there is a bus park. You may say, I have focused on the market for this week. I may go to the bus park, because the people of the bus park are not coming. If you can move them. So the issue is to try to screen as many within those. But there are some places, you know, TB, that's why we came even to these peri-urban areas. If you imagine, all of you where you come from, there is a town. Iganga, Hospital, Bujiri, Hospital, Sembaru, Butenga. There is a what? TB, as you know, is a disease in the towns. Kampala has more TB than most of the places in Uganda. Because we sleep next to each other. In our villages, where one person is there, another one is the other side, there are very few cases. So you find that TB is an urban disease. We came to those, and at the same time, you will find that even your hotspots are those places which seem to be highly congested sometimes, because transmission occurs very fast. Yeah. So, study staff will recruit participants in the selected hotspot policies throughout the intervention period. We will place screening station in heavily trafficked areas such as transit hub or market or hotspot, and we recruit by interacting with pass-by or by visiting nearby homes and shops when enrollment slows. We will engage leaders and VHTs to help spread the word about the availability. So imagine when you have so many people at the screening, it's like even vaccination for COVID. Now once the people are not there, you can move now to the community and start telling them about, have you screened for TB, and you explain to them and other things. So people can be able to, and so on. But having the leaders, community leaders and other VHTs, to be helpful to inform people about this. Yeah, so additional activities at the health facility during all intervention period: expert testing at the facilities lab on sputum and delivery. And as we said, we are working within the system. If something is happening and there's shortage, we should work together to make sure that either supply chain is, or we provide some logistics, cartridges and others to make sure that this does not stop during the period. Storage of study equipment in a safe place, I have talked about that. Evaluation and treatment of patients referred by the study team. Those diagnosed with TB and needing treatment, they will be treated by the clinicians who are doing the work. Those identified eligible for TPT, they will still get TPT through the designated. Those referred for further evaluation on any non-TB abnormality, we talked about them. And communication between study teams and facilitator as needed to determine whether patients diagnosed with TB have been linked to care. And we shall try to see those patients which were referred, were they put on treatment or not. The other study activities, here as I said, study staff will collect data from presumptive TB register, TB treatment register, lab register, and TB register. And this data will be collected every 4 months. Every 4 months, people will look at the register to see how data study team will take temporary photos of register pages to minimize workflow interruptions. So instead of coming and you want to look at the register page by page for the 4 months, if you come with a smartphone and you take a photo of this page, and take a photo of this, and you go and analyze that, what may not be clear, then you can come back and ask what this is and this. But so that we minimize, because register in use. So if you want to just, and maybe people can seriously do this taking of photos in the evening when the register is not that much in use. And those are innovations that can be adopted by working with the clinic staff. Tracking of study outcome will require complete accurate register, in particular patient districts and county Paris residents and others. And as you've seen, TB data has been very good quality in the lab and the other registers. Just keep it up, because sometimes that information is important to inform us also of how things are working. So finally, our outcome really, what are we going to compare? I've talked about this, the difference in the number of study region residents notified as initiating treatment for bacteriologically confirmed TB within 2 weeks of the intervention period, comparing periods which have been randomized to hotspot focused approach to those randomized to facility-based approach. So this is what we shall be comparing, and this is like the AIM-1, bacteriologically confirmed pulmonary TB, how it is being implemented, whom have we reached with hotspot, or whom have we reached with facility-based. And we shall also look at the cascade of care, screened, had TB, how many screened, complete screening, put on treatment, then complete treatment. So we shall look at the cascade of care, and as I told you, we shall also project in the future to see what is the impact of doing this. What does it mean? It's like the screening. You screen for cervical cancer early, you prevent the disease and you prevent downstream expenses. So we anticipate that chest TB will reduce the TB burden in those study communities. That's why we need a comparison group. That's why some of us will end up into the comparison group. And you continue to carry out activities as we're carrying out, while also generating results that can inform scale up of that active case finding. So as the NTP and others, we are partnering with them, and this will help us understand if you scale it up in other communities where you suspect to have TB, then what does it mean and what does it cost? This time we're going to use it. Yeah, but the signing you should first read through very well. And because it is, you are concerned that we can use this photo in a presentation of Ministry of Health. So you should read it. I don't want you, there is nothing that you have to say. Whether you sign it or not, we are going to participate in this study together. It is not, but I want you to read through. You know, sometimes, especially, have you ever borrowed money from the bank? If you borrow money from the bank, they are those small words, and when you want money, you don't want anything to disturb you. You just don't even read them. Then they say, we saved the interest with income, but I never saw it. Dr. Rodrigo has a question.
Yeah, thank you so much. My question regards, thanks for the presentation and for making us understand. You mentioned something about a pragmatic approach, doing things to make sure that just the same way they are happening. And on the intervention of providing TPT, which is TB preventive therapy, I realized you first actually test people with TST, the tuberculin. Some. For those who will fall in the intervention, right?
Yeah.
Yeah, but currently, in the eligibility for TPT, much as it is in the guidelines, we don't have the TST as the normal routine operations Ministry of Health. We give people TPT just because they are living in the household of a TB patient. So, isn't
pragmatic
that
aspect.
against the pragmatic? Thank you.
Yeah, that's an important issue. That's should we give everyone TPT? One of the things that has been shown that majority of the people never report what TB. Majority of the people never what. The tests we have currently for TB preventing surgery, they are good, but they are not that very good. And actually, there may be some new tests which WHO may be endorsing very soon. And those new tests probably we may even adopt them if they are adopted. But you would want to know really, because even earlier on, if you remember, the National TB Program was testing out IGRA. I don't know where they started ended IGRA for routine use. Muchuro was the team. They were trying to see IGRA so that still, as much as we think that people should not be screened for TB be given, the chances of compliance even become or adhering to the treatment. And even in terms of treatment, we are happy that the national program has also endorsed 3HP, I think. And if that is even available, it makes it easier. So yeah, it's true that it may differ a little bit, but you want to see who, because these people, we are meeting them in the community and others. But as you say, it is maybe a little bit not as what we are doing. But I think it is sort of recommended, though it is not available. But I think in terms of the recommendation, so it would be not right for us to do it in such a study when it's recommended and just do it. But anyone wants to add on.
Yes, thank you, and Rodrigo, thank you very much. IGRA, we actually scaling up IGRA to all the regional referral hospitals. We will get the equipment, and we will be working with the regional referral hospitals. Actually, we even want to add district hospitals eventually, such that the samples are collected. It's like a human start. So samples will be collected, and then the state will use the machine, which is at the regional referral hospital, district hospitals, and results will be taken back so that patients can decide on TPT or not. Now, in terms of EST, being a study, I think it's okay, because that also helps us understand more as a program whether TST is going to be viable. If it is viable, we'll get it against from the study. And if it's not viable, then we will know then how to go. So the recommendations that will come out of this, using the TST, and then being able to start patients on TPT, it will be able to help us. So Rodrigo, whereas we are in the policy, our interest is to make sure that we get all the contacts of TB patient adults to be studied for treatment, which we are doing because of the resource constraints. Yeah. But with the availability of now TST, it sharpen our recommendation further to say, rather than just starting, can we make sure we do something about testing for those that are on study PT? Thank you.
And then there, I think early next year sometime, there may be some other new tests WHO is going to have.
Yeah, there are some that are already.
So, and those may even be helpful. Because, some of the tests we have now, the probability of developing TB over time is very low, even when you are positive. And so there are many people who end up for nothing. That's why that area is still a bit gap. Kasambia, Iganga, Bujiri, and Luero, the last one.
Yeah. We- So that is what we have selected all. Do we agree? There is no bias. Okay, now we can move to the next session. So now that the triplets can now, you can see the 3 clinics we have sort of. So now the next step, we need to convert the arbitrary labeling. As you can see, this labeling were arbitrary arm A, arm B. We are now going to change this arbitrary labeling on triplet 1, triplet 2. We've already selected the other. So we are now going to get more bows. But this time, since we did not get bows, we got paper. This time. Is this the one with? Yes. Yeah. We have 3 papers here, which are labeled on A, B, C. They are here. I want to show them to you. They are wrapped in a similar way. Sometimes they come when they're packed already. Now, we wrap them in. You see, this is C. This is and this is more volunteers. Yeah? More volunteers. There are even others coming there. Still, this time, ladies first. Bring the second bag also because big one, eh? Okay. Okay. Now the second, this volunteer, what she picks, eh? Another volunteer is going to pick from this bag, but and what he picks from this bag will match, will be the name of the arm, whether active case finding facility or hotspot. You see? So the volunteer has picked first. Another volunteer is going to pick first here. What she has picked, whoever picks first will be the name of that, whether hotspot. So, but before you can show what you have picked. Yeah, what has she picked? She has picked A.
Yes.
Which means the name that is going to be picked from here
Will be the
A. But I have to first put them out because there may be more. And we have also to see which names are here. See? Control. Clinic active case finding. You never know, the clinic may be too. When you say obvious, put back, you may be surprised.
Okay.
Aha.
You cannot stay.
Yeah?
Clinic, all of you have gone back.
Are you the volunteer? This is the volunteer who wants to partner with her. Put in your hand. You come here. A is
Clinic.
now we want another volunteer. Have you noted that? A is so where you see the name A now, which was arbitrary, is now what? Clinic. It means another volunteer this side. Oh, he's already here. This is good.
B.
B. Yes? B. Now, you have another volunteer this side. Put in your hand.
Okay.
Now it is obvious. Eh?
Yeah, proceed. What?
No, but you can pick and find out. You never know. You might not be there. Some volunteer come. We know the obvious is what it means, but you never know. Things can change when they go in the bag. Pick. You have picked that one, or you can pick again. They have allowed you. They said you can pick again. And you can show them both that they take a photo. So that at least we take a photo and capture this control area, and you put also the B, the what? The C. So, things are still going on well. So far. So now we are going to the next step. Yeah. David, so far we have finished those two steps as you have observed. So, and we have seen our randomization sequence in here 167. Now, we have come up with A is SCF. These are the ones we have finally come up. SC. Then we have C control and B. This. Okay. So the last step, we now know which clinics are in, but we would want from each of these triplet. Maybe, David, could you increase the font size so that the names are more clear or presentation mode? Yeah, so from each of those,
Yeah, I'll try to increase the font size, but it's going to throw off the table, unfortunately.
Oh, but maybe put in presentation mode. We want at least a representative from each of the triplet. There are 4. And we are going to select when it starts. You remember that? We are now going to select, there are 4 starting points. It doesn't matter that if people have ended up into the control arm, they can't be volunteer from that to select the starting time. So we want from each of the triplet to at least you can select 1 member from the triplet. The 3, in other words, the 3 what? The 3 was like Kayunga, Kaolo.
So from here, what you are saying, Kayunga is the facility SCF.
No, we have decided on
It's not Arm A.
Arm A.
Kayunga is Arm A.
If you are in arm A,
Or you are saying,
A is clinic. It is say clinic.
yes, clinic.
A is clinic.
Yes.
Those people, before they were habitual.
They were habitual.
Now we have named
Now
them.
we have named them. So Kayunga, Zimbabwe, Nagaseke,
Here,
and Iganga.
exactly.
Okay.
These ones which come first in every triplet
Yes.
are now clinic.
Yes.
Because we have named
Yes.
arm A.
I'm A.
Arm A is clinic based. Are we all together? Yes. So arm B
Then I'm B
is
Kawolo,
hotspot.
which is hotspot. Kawolo. Chazanga,
Yazanga,
Kasanda,
Kasanda,
and Ujiri.
And just to confirm that you know, Arm A is just doing the clinic based first. That will then rotate to the hotspot. Similarly, those who are doing the hotspot first will rotate to the clinic. So it's just which one you're doing first, not which one you're doing for the next 3 years.
Now I get it.
Yeah.
At one point in time, the Arm A will do Arm B.
Yeah.
Now what we are going to do is who in the Arm A goes first.
Yes. Now we are
Who
going to say
is now going to be selected to start?
the 4.
The
So
four,
it will be from this triplet as much as Gombe is now control.
Yes.
Eh? But even if in this triplet we want one volunteer
Yes.
to select the starting time,
Yes.
so that if this group decides when to start the first, then it will be the first to start. You saw that picture where
You take us
David,
that picture.
David, can you push back to that picture which shows the timing
The timing.
of start?
Sure. So
That
so what?
That
Yeah.
one.
Yeah, that
Right. So some will be starting almost immediately, so in about a month. The next wave will start 4 months after that, then 4 months after that, then 4 months after that. And whenever you start, you'll do your first allocated intervention for the first 4 months. Then there will be a 4-month washout period, and then back to the other allocated. So if you are in the clinic first arm, so arm A, you would start with 4 months of clinic-based active case finding, then 4 months without the X-ray, then 4 months with hotspot-based active case finding, then 4 months without the X-ray, 4 months of clinic, 4 months without, 4 months of hotspot, 4 months without, 4 months of clinic, 4 without, 4 with hotspot. And this allows for each arm or each intervention to be performed over a full calendar year. So you can see here it would be like December, January, February, March, then April, May, June, July, August, September, October, November. That way, no one intervention is getting favored in terms of the timing. So for example, we are expecting to see fewer people getting diagnosed during the Christmas holidays or something of that nature. Those that start first will also be the first to end. So each arm will have a total of just about 3.5 years of the intervention. And so if you start early, then you also will end early. Those that start late will also end late. So that'll be the overall timing. And we're just trying to figure out which ones start first, start second, start third, and start fourth. So we'll find out who our two guinea pig communities are, so to speak, those that'll be starting the very first.
Yeah, so now that's the next phase. We are going now to decide. That's why we were saying you can pick a volunteer from that triplet. The triplet which had those 3 clinics based on our 167, the first triplet, one ended up into control. So you can select one from those 3, come and select a number. When do you start? And there are 4 starting points. And these are all labeled. This is number 4. First check, you never know. There may be 2 4s. Okay. So this is number 4. This is number 1. They said will be the GNP. We shall be running as we go with that one. This will be number 2. And this must be 3. Are we together? So now we want volunteers. 1 volunteer from each of the triplets.
No, the triplets.
Yeah, it can be, you can say the 2, but the 3, because there were 3. One is in control, but even the one who, so 1 volunteer from each of those. There is Kayunga, Kasanda, is it Kayunga?
Kayunga,
Kawolo?
Kayunga.
Kawolo and Gombe.
Eh.
Someone can come, 1 person from that group. Another triplet is Sembabule, Kasanda.
Zimbabwe, Chazanga,
Chazanga and
Butenga.
Butenga, also another. This one is
So let's have some Kayunga, Kawora, and
Gombe is here. Gombe has already come.
Wait.
You wait a bit.
No, I want
Now,
to
this
see
one
the
is from where? Yeah? You are from Kayunga. No. Now, you decide the
and
two.
Gombe.
Who should you select?
Kayunga, Kawora, and Gombe. Where are they?
You are Kayunga. This is Gombe. This is
Yeah, that
Kayunga.
is Gombe.
Now, you decide one who is
So
selected.
who is the they can see them walking away.
So now, Gombe is going to select 4, that triplet. Then in the next one, when are they starting?
When are they starting? They are starting.
They are third.
They will come in the 3rd year.
No, they will come in the 4 months, then the next 4 months, but the third 4 months. So it will be like first 4 months, then the second will start after 4 months, the third will start after another 4 months. Yeah. So that's around a year.
That is wait.
Yeah, so we'll be starting around January.
That is
So,
that's the first one.
that's the first triplet. Kayunga, Kawolo, and Gombe. Gombe is control, but these 2, they already selected. Kayunga selected that it's going to start with clinic.
Yes.
And this is going to start with hotspot.
Yes.
So, but they have selected now to start as 3rd.
The first way. Let him go to that.
David, you go back to that picture, which shows the timing of starting. They want to look at it.
Yeah, so the months here will be offset by about 1 month. So the first, and maybe even a month and a half.
Yeah.
So the first communities will be going in starting in May.
Yeah.
Okay.
Meaning, so for example, if green is the clinic based,
So that is
then that would be
Kayunga.
Kayunga.
Yes.
And so what we would have is Kayunga would be community 5 in this group. So it would be starting again. It will probably be January to February.
And then
And then at that same time, in the hot spots, we would be starting Kawolo.
Yeah.
yes.
And so that would have, so Kawolo would be community 6.
Community 6.
And like we'll be visiting the control sites the same way that we would visit the intervention sites. So you'll see us around that time in Gombe as well.
Yeah, that's now noted. Next.
Okay, thank you. Number 3, we are not going to replace this time. So now, next triplet is
Sembabule, Chazanga, and Butenga.
Aha.
One of you should come out.
Sembabule, Chazanga, and Butenga. Someone should come. Chazanga is come to represent.
I hope you have picked one or not.
They want the team. We are selecting a number for you. They said that I looked at the in charge there, I looked at him and said, number 4.
Can we go to the chat and
We go to the chat
and get the community?
the communities.
Yeah, who is the community number 1 in the chat? Because Chazanga is community 5, Kauru 6, Gombe is 11. So now we want to know Sembabule, which is facilitated.
In terms of the communities,
Yeah.
they are the community number 9 and 8, 9 and
Yeah, the last one.
So Sembabule would be community number 7. And then Kyazanga would be community number 8. And
Butenga.
Butenga would be community number 12 in this case.
Yeah, thank you. So, thank you very much. And actually, the program manager in this case, you are taking note of it. Yeah. You asked me. That's very good. Now who's the, now the next triplet is
Nakaseke, Kasanda, and Kasambia.
and Kasambia, a volunteer. Nakaseke, Kasanda, and Kasambia.
Who you?
Hey, Kasambia is coming, yes? What will be the first
Don't look
one?
there. What will be the first?
What? Okay, open.
Open.
We are the one starting.
Yeah.
So Nakaseke and Kasanda.
Nakaseke is community 1. Kasanda is community 2.
Yeah.
And the
Kasambia is
Kasambia is
Is community 9, that's right. And just to say, if the representative from Kasanda would be willing to stick around at the end, it might be helpful for us to talk with you about how to identify your first hotspot.
Yeah. Okay. Yeah.
So now
the last one.
the last one.
It is not automatic.
Okay. And the last one, what the big? That's the Iganga, Bujiri, and Uwero. Yeah. Someone from Bujiri is going, and the BHO, the MSC, the medical secretary, is deciding to say where to go. You have to confirm. Yeah. He said he had to confirm. So, Iganga.
Community 3.
Iganga is community 3.
Ujiri community 4.
Ujiri community 4.
And
Uwero
the-
community 10, I think.
Uwero community 10.
Yeah.
10, 11,
Yeah.
9, 10.
Just to ask, has this been a fair exercise?
Enough.
Enough.
Good, very fair.
That's great. And maybe I would ask David to give a few remarks before I invite our Assistant Commissioner in this case, but also Dr. Raymond, he also NTLP to give some closing remarks. Maybe David, I call upon you first to give some remarks.
Yeah, thanks very much for everyone. I think this has been a fun exercise. I hope you agree that it has been fair, and I hope that we have set this up so that it has been balanced. I feel like I owe a lot of statements of gratitude. So first of all, to Dr. Raymond and to the NTLP. I know that Dr. Stavio is not able to be here today, but for supporting this endeavor and helping us to align this with the priorities of the National TB and Leprosy Program. Also to each of you who traveled in many cases quite a long distance to get here today. Really appreciate the time that you've put in, and it's great to be able to launch this with you. And for many of you, I hope to have a chance to see you in person when I come out to Kampala next. Also to the UTURC team for putting this together, to Achilles for coordinating all of this, PK for getting a lot of the logistics in place, and to the rest of the team as well. I won't name everyone by name, but really appreciate the UTURC team. Also to Dr. Nanyane for coming up with this randomization scheme. And to Catherine Fielding for her initial randomization slides as well. Emily Kendall unfortunately was not able to be there, but she is the overall PI of this whole project, and so really appreciate her leadership and guidance as well. And so I think that it will be very exciting to see this get underway. We've been planning this for a few months, and we're about to start our trainings. Very much looking forward to partnering with each of you. Again, as I mentioned before, we can't do this alone. The entire idea behind, for example, selecting the hotspots and understanding how this could get implemented in the clinics depends on you and your knowledge of your local areas. And we want you to help us implement this in a way that can be generalized to the rest of Uganda and even beyond. So really looking to work with you on this project, and hope you all have a great weekend, and look forward to launching the study very soon in a couple of locations.
Thank you very much, David. Thank you so much. And you know, we need to say, David, it is 3 or 4 a.m. in the United States where he is, in Baltimore, and he managed to be with us from 2 a.m. instead of sleeping up to now, probably, and he's just going towards the morning to wake up and he starts working. So, David, thank you so much, and we wish you the best. Maybe at this juncture, we'll call on Dr. Raymond to say a few remarks and officially.
Okay. Thank you. If I make a few remarks,
Yeah.
can I kindly request one of our medical superintendents
Yeah.
to say just a word of it?
That's very good.
One of our medical superintendents, I know we're in partnership with the facilities,
Yeah.
so maybe in one of our
One of
hospitals,
us make hospitals.
and then we can have one of our IPs also to just
Yeah.
say a word or two, and then
Very good.
shall close. Thank you. You also want the regional TV for
Gender
capacity?
balance.
Kamate Samuel, DHO Tambala.
Okay.
But also MS Gombe Hospital. So we are going to handle it at once. Yeah, so first of all, thank you very much for coming in big numbers. I think Dr. Katambesi is very good. When you invite us, we all come. And I'd like to thank the team, Dr. Katamba's team. I think every time I look at these studies, I see a lot of thoughts. People think. People do a lot of thinking, and usually for us we are at the tail end. We come and randomize, and then the community benefits. So thank you very much for thinking. And I think we should also I'm always challenged. I'm always challenged by the thinking. Someone thinks about something, it's a concept, it comes out as a study, but people don't know the studies. People know the actual health. The X-ray is going to a community, and people will get diagnosed, and they will actually be treated. So for me, that is where the thinking is. But from the ministry, I know it's the environment, the conducive environment you give to the thinkers. To my colleagues on the ground, the people who have actually done the selections, thank you for doing what you do. Thank you for receiving everyone who comes. You know you come, and we receive you and we work with you. So thank you very much. And I come from Gombe. We are controlling. Sorry, I was saying, so Emily can select when we start controlling. So she came and selected. Yeah, but really, for me, it's about thank you for everyone. And it's always exciting. TB is there. I was part of the CAS TB, and TB is actually a problem. So any work we can do to get it handled is work very welcome. Thank you very much.
Our IP, Monica, this time, you know, gender balance is also very big issue.
Good afternoon, everyone.
Good afternoon.
Yes, thank you for coming, and we also want to thank very much the thinkers of all this. I see the TB agenda is really, we are being interested in it so much because of what the team from School of Public Health and all of us are doing, the Global Fund. At least increasingly, TB is receiving attention, and whether we like it or not, it will find us in different places, in the marketplace, in the taxis, in our homes. So we have to do something about it. So with this study, thank you so much for bringing us together, because if we didn't have this meeting of today, we would be complaining maybe, how did I become a control group? But everything was so clear here. And we now understand the process, and for us who are learning as healthcare workers, it also opened our eyes for future studies. Because if we have to help the country as gatekeepers, as custodians of health, we need to do the research to back the policies and really impact on the communities. So on my side and on the side of the IPs, we appreciate this process of sitting in the same room, because it's the same people we deal with. And I always say, when you see MOH, IP, district, it's all of us, because we work as a team for the one person, that one patient in the community. So this has been great. I also, in a special way, also appreciate the teams. I'm sorry for being a bit sectarian, but the teams from my place, that is Kaolo Hospital, is well represented, and Kayunga. So thank you for also showing that interest, and I'm sure we shall participate in this study and bring good results. Ours is excellence all the time. Thank you.
Thank you very much. Yeah, so now since there was someone who doubled, I think continue doubling. Say that you represent both groups. So now I invite
Thank you very much. David and Dr. Katamba, we want to appreciate the exercise we've gone through. Indeed, as Dr. Monica said, at times these things, once we do them in our rooms, in our offices, there are many questions that will always be asked. So once the whole team is here, then we appreciate in one way or another. To my fellow colleagues at the districts and at facility level, we really want to appreciate your input, your time that you've put in to be here. I again want to reiterate and say, even if you're in the facility arm or you are in the control arm, services must be delivered. And we are going to make sure we work together to deliver the services. Status quo or standard delivery of service, even in the control arm, will continue. I want to give you assurance. Some of you in your minds might be saying, now that I'm in the control arm, I'm not going to get X-ray services. The government of Uganda, Ministry of Health policy today, tomorrow, and in the coming 100 years or 10, 20 years to come, we are going to have a digital X-ray at every district hospital. And if a district doesn't have a hospital, we shall put it at the biggest health center within the district. So that is the agenda questions. Discuss them. If you want some technical support, Dr. Andrew is around and the team, and you can think and then you see how you can be able to implement it. So I want to encourage you, let's go back, implement this chest TB by chesting out TB. You know, now TB is one of the only, I think one of the biggest diseases that has the best acronyms. Some of you know DEFEAT. We have chest. We have CAST. Catch up. We had speed. We had track. TB. So there are quite a number of these acronyms. And we have Stop TB. We all know of our agenda to end TB. So we also have End TB. So we have all these CB dots. So we have many acronyms. But at the end of the day, the essence is to make sure that we end TB by 2030. And we're on track to end TB by 2030. At the rate at which we are moving with our finding those missing people with TB, we should be able to see some dent in terms of our TB in 2030. But with those few remarks, I want to thank you very much. I want to thank everybody. Thank you for your time. Thank you for your enthusiasm to make sure that we find more of the missing people with TB. And we look forward to a very successful implementation of this project, HSTB research. Thank you very much.
I think that brings us to the end, maybe the people of logistics and others, that in my culture, when the big drum has sounded, the small ones cannot do. I will hand over to people of logistics.